Welcome to the All Things Celiac webinar series brought to you by the National Celiac Association and the Harvard Medical School Celiac Education Research Program. Today, we are happy to present to you, staying on top of the news, highlights from the 20th International Celiac Disease Symposium. My name is Chris Rich, and I am the CEO and Executive Director of the National Celiac Association. We here at NCA provide educational resources to our celiac community, such as this All Things Celiac webinar, and we continue to value the opportunity to work in collaboration with the Harvard Medical School Celiac Education and Research Program to bring such initiatives to you. In addition to our educational programs, the National Celiac Association helps in assisting people facing food insecurities and offers an extensive support network that reaches from coast to coast and assists everyone from kids and their families to our celiac seniors. You can find more information about the ways that we support our community on our website at nationalceliac.org. The highly collaborative Harvard Medical School Celiac Education and Research Program was founded in 2013 and has a twofold mission of developing and promoting the latest research in celiac disease and advancing awareness about celiac disease through educational programs to clinicians and the general public. Education is at the heart of the HMA's Celiac Education and Research Program, and these webinars continue to feature multidisciplinary speakers with specialized knowledge on celiac disease, related autoimmune conditions, and nutrition. For today's event, you are welcome to ask general questions through the Q&A feature. You can find that located at the bottom right corner of your Zoom screen. Closed captioning is also available by clicking on the CC button at the bottom of the screen as well. For those of you who have registered for continuing education units, please fill out the survey that will be added to the chat box during the webinar. If you are still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org, or you can reach us by phone at 857-282-6470. This session is also being recorded and will be available for viewing on the National Celiac Association website. That address again is nationalceliac.org, search webinars. Our moderator today is Dr. Dan Leffler. Dr. Leffler is a practicing gastroenterologist caring for patients with gluten-related disorders, including celiac disease and other gastrointestinal disorders. He is a founding member of the Celiac Center at Beth Israel Deaconess Medical Center and Associate Professor of Medicine at Harvard Medical School. He has received multiple grants from the National Institutes of Health, numerous foundations, and industry members supporting his research to advance digestive health. He has authored or co-authored more than 150 articles in peer-reviewed literature and co-authored a patient-focused book with Melinda Dennis titled Real Life with Celiac Disease, Troubleshooting and Thriving Gluten-Free. He joined Takeda Pharmaceuticals in 2016, where he is the Senior Medical Director and Global Clinical Leader for celiac disease in the gastrointestinal therapeutic area. So let's begin by saying, welcome, Dr. Leffler.
Thanks so much, Chris. Welcome to everyone joining. Thank you so much. I am really excited for today's presentation. Again, just a reminder, if you have any questions, please put them in the chat. We got some wonderful questions before the meeting that we will try to address as many of them as possible. I will tell you right away that we will not be able to get to all questions, but we'll do our best to do so. And with that in mind, again, this is going to be an exciting session. For those of you who are unaware, we recently had our International Celiac Disease Symposium. This happens only every 2 years and brings together the best and the brightest across the world in celiac disease. And this meeting held just a little while ago, and Sheffield, UK was no different. So excited to introduce the first of our speakers. We have three wonderful speakers, all amazing scientists and colleagues. The first of them is Jocelyn Silvester. Jocelyn is MD, PhD, is an assistant professor of pediatrics at Harvard Medical School and the director of research for the Celiac Disease Program at Boston Children's Hospital, as well as associate staff at Beth Israel Deaconess Medical Center. She also maintains a general pediatric practice in northern Manitoba and Nunavut, Canada, through the ongoing Muse Health Services. Dr. Silvester is a co-chair of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Celiac Disease Special Interest Group and serves on the American Gastroenterology Association section for basic and clinical intestinal disorders. Her research includes diagnosis and management of celiac disease with a focus on what happens after the diagnosis of celiac disease is made. She's also co-investigator on the important Manitoba celiac disease cohort study. She's involved in clinical trials for alternative therapies to a gluten-free diet and is leading a consortium of pediatric clinical centers across the United States to develop better tools for follow-up care. Jocelyn, thanks so much for joining us today.
Thank you, Dan. It's great to be here, and I'm excited to talk about some of the things that we saw at ICDS. Unfortunately, I can't cover them all, but I'll start with some disclosures and then hop right in. I decided to focus on two sort of compelling questions that I get asked a lot in clinic that there's lots of people working in different ways to find answers. And so the first question is, how much gluten can I have? Because we all know that a gluten-free diet isn't 100% gluten-free, but we want to avoid gluten, and what's the line? And so this is an interesting study that was done in Australia, and what they decided to do was see how low can you go and see a response to gluten. And they were able to do this because we know that one of the things that defines celiac disease is having T cells that recognize gluten, and when they recognize gluten, they react, and they react by making chemical signals that make your body do all sorts of things. And one of them is IL-2, which makes you vomit. And so they were able to do this study using this as a biomarker. And the question was, if this is the biomarker, how little gluten do you need to be able to see a detectable change after a single dose in people who are already on a gluten-free diet? So they started with 1 gram and worked their way down. And they measured at baseline and then at 2, 4, and 6 hours. And they also had a placebo group so that they could know what the baseline is. There were 36 people who had 3 doses. They were mostly female, which reflects the population with celiac disease. And importantly, there was no serious adverse effects. And interestingly, there was no significant correlation between the symptoms and the dose. But this is maybe part of the story. So this is a plot showing how many people had a response at different doses of gluten. And what you can see is that most, but all people responded to 1 gram, which is somewhere around the fraction of a piece of bread. And there were fewer people who responded to 5 milligrams or 3 milligrams, which is getting into the crumbs range. And so if you think about, okay, well, what was enough for half of people? This was actually 610 milligrams, which is more than half a gram, which is a reasonable amount of gluten. So when we think about this study and how we're going to use it and what comes next, I think it's important to remember that measuring the biomarker it's a proxy, but it's not exactly measuring the disease. And so we don't really know what the impact of these transient levels of IL-2 increase are on actual end organ damage, such as the intestine. Also, I think it's a very nice way of showing something that we hear in clinic all the time, which is that different people have different thresholds for how much gluten they feel like they can tolerate before they get a reaction. And so maybe this is a model that we can find out more about that. The next question is can I eat pizza, Cheez-Its, or insert other food that doesn't really have a good gluten-free alternative? And so there's 2 groups that looked at this in 2 different ways. And the first group, which is from Italy, decided to take these glutenases and see if they could detoxify gluten. So we know that gluten is a protein. It's made by plants like wheat, and that people with celiac disease recognize certain parts of it, and those parts don't get digested very well, which is why they're still there to be seen in the intestine. But bacteria, some of them are actually very good at breaking up gluten. And so what if you took a bacteria glutenase and sort of made it into a treatment, just like we have lactase for gluten? And so there's a few companies who've done this, and they decided to test them. And what's interesting about this is how they tested it, because we know that if you just give gluten powder, that's different than if you give gluten in chocolate or gluten in food. And so they specifically looked at pizza, which of course has fat and everything else mixed in. And they used a simulated digestion. So they had the pH controlled and they had the enzymes that people usually have. And they put the pizza in, and then they also added the glutenases. And they had 2 models. The first one was for the stomach, and then the second one was for the stomach and the duodenum, because there's more digestion that happens in the duodenum. And after it was done digesting, they then measured how much gluten protein was present. And then they also took what was coming out of their simulated stomachs and intestines and put it on cells from patients to see if they reacted. So sort of analogous to giving the patients the gluten in real life that we saw earlier. And so when they looked in the stomach, they found that the enzymes were actually pretty good, but there's more digestion that happens later on, and that gives the control somewhat of a time to catch up. So this is a percentage of what's left of the control. So there's actually less left in the duodenum, but the control has almost digested it all as the enzymes have. When they looked at the T cells, what they saw reflects this. So when they looked at what was coming out of the stomach, none of it was really to a point where it wasn't activating the T cells. When they took it to that next step and put it in the duodenum, they found that even though they could detect more gluten, the ones that were coming from the duodenum were not as stimulatory. The immune system didn't react as much. And I think this is really one of the really important lessons from this paper, is that not all gluten is the same, and some parts of gluten are more dangerous than others. And it's really important to know what part of gluten you have and what you expect it to do in order to understand how dangerous that might be or how toxic it might be. I want to just note, it looks like supplement 3 is somewhat good here. That one is not commercially available, so you cannot buy that on the shelf. Limitations and clinical implications of this. Of course, it's not real humans, it's not real stomachs, but it gives us a good model. Also, the test they used was the test that's usually used to test food, and it clearly, the amount that they saw there didn't correspond with the immune response, which shows that it's not a perfect test for gluten that's going to affect people with celiac disease. And we still need more data from human clinical trials. Now, one approach is to take the wheat that has gluten in it and try and make that less toxic after you eat it. Another approach is to take the wheat and try and take the gluten out of it before you even grow it and bake the pizza. And so that's what this group did. And so we know that wheat has gluten and gliadins in it, and that these are actually important functionally because they affect how things stick together, which affects the quality of baking. But they also have that downside for people with celiac disease because they drive the immune response. And these are proteins that are made by these plants because they have them in their genome. And so they're able to make that sequence just like we can make hemoglobin as humans. And so what they decided to do was see, well, what happens if you delete some of these genes? And so they looked specifically at alpha gliadin, and they took a specific strain of wheat. And plant genetics are really complicated because, unlike us, they have multiple pairs of chromosomes. So they looked at chromosome 6A, B, and D. And then they tried to grow it after they'd made their genetically modified wheat, and then they tried to make bread out of it. And so as somebody who's not always that successful, I think the most exciting thing about this experiment was that the plants grew and survived, and they actually were able to get to the fun part, which is making the bread. And interestingly, the amount of protein was not changed, because we always think of gluten as a way that plant stores protein in case it needs it in the future. And so the plant was switching to other types of protein to store because it couldn't make gluten. It wasn't just missing out on the protein, which is probably why the plants grew fine. The first mutations didn't affect the quality of the bread. And interestingly, the second mutation actually improved the quality of the bread. And they didn't describe exactly how, but they had a scale for rating this. And they thought that this was related to some of the types of amino acids that were in the genes that they deleted. So I think this is another exciting approach. And it's a good, interesting experiment. This is looking only at how this wheat performs. It's not looking at if it looks any different for people with celiac disease. And I think one thing that was really interesting about this study was that they actually stated that their goal was not to make wheat that was gluten-free for people with celiac disease, but they wanted to make wheat that was less immunogenic. So maybe if people ate that wheat, they'd be less likely to develop celiac disease in the first place. So hopefully more to come on this. So then the last question is, these have all been human or in vitro studies, but we also have a mouse model for celiac disease. And so the question then is, well, what can we learn from the mice? And so can we do something to gluten-free celiac mice so that they can eat pizza? And so this is looking at one of the drugs that's being developed for celiac disease called TAC-101. And what they did is they this is a drug that is injected, and it essentially presents gluten to the immune system in a way that those T cells don't get as excited and don't stimulate the same type of immune response. So over here on the right, you see some data from humans where they gave them this drug, and the ones on the left who got placebo, they still had an immune response after getting the drug, but those who got the drug had less of an immune response. But the question is, well, how long does this last? And what does this really mean? And so one nice thing about mice is that they're easier to recruit and they grow quickly, and they're usually 100% adherent to the study protocol. And so having a mouse model helps push things forward. And so what they did in this study was they took the celiac mice and they gave them either no drug or just gluten or gluten plus drug to see what happened. And what's important about this is that they actually gave the drug before they gave gluten. So this is pre-treating the mice before they have celiac disease. And then at various times, they looked at the immune responses. And what they found was the ones that didn't have anything, that were just normal mice, they didn't make any anti-gluten antibodies. The ones that got gluten and didn't get the drug had a good response. And the ones that got gluten and got the drug, the blue ones had sort of an intermediate response. And what's interesting is that it looks like it maybe persisted because the response at 1 and 3 months was both good. So exciting and interesting way of testing drugs and getting some information. Of course, this is a mouse model, so it's not 100% clear how that would translate to humans. And also the other limitation related to the fact that in this model, they were actually giving the drug preemptively before the mice had celiac disease. So those were some of the things that I thought were exciting at ICDS. And I know there's lots of more things to hear about. So thank you.
Thank you so much, Jocelyn, Dr. Silvester. That was fantastic. Just one quick message that I forgot to mention, and thank you, Francie, for putting it in the chat. Just a reminder that we do have CME, CEU, and CE credits available for this session. So if you are eligible and interested for those, please fill out the survey link you see in the chat. But with that, happy to introduce Dr. Nan Du, who is also a pediatric gastroenterologist, received her MD in 2016 from the Warren Alpert School of Medicine at Brown, and completed her pediatric residency at Yale New Haven in 2019. She has a master's in public health and clinical effectiveness with a focus on environmental toxin exposure, health services research, and large databases. Her main areas of expertise are celiac disease, other small bowel disorders, and nutrition. And she completed her pediatric gastroenterology fellowship right here in Boston, also at Children's Hospital, where she is a working clinician scientist researching celiac disease and early infant nutrition. Thank you so much, Nan, for joining us, and feel free to pull up your slides and we'll get going. And again, we will get to all the questions at the very end after all of our presentations.
Thanks so much, Dan. And so good morning, everyone. I'm delighted to provide some pediatric highlights from Sheffield, and we're going to get right into it. I have no disclosures. This is a very brief outline of what I'll be reviewing. I took a selection of some of the pediatric focused talks as well as some of the posters that were presented, and I'm going to start first on epidemiology. Talk 1 of the clinical forum at the International Celiac Disease Symposium was a wonderful updated review of the progress of a project called CDGEM, which stands for Celiac Disease Genomic, Environmental, Microbiome, and Metabolomic. It's a prospective longitudinal birth cohort study by our colleagues at MGH, which enrolls infants at risk of celiac disease in Boston and Italy. Specifically, the team has worked to examine the infant's microbiome and metabolome during the first 6 months after birth in relation to environmental risk factors and genetic markers known to increase risk of celiac disease development. So if you look on this slide, they kind of have a population of those who are genetically predisposed and then looked at those on certain risk factors such as C-section, formula-fed, and antibiotic exposure. And this on this slide is their initial study where they found that there was a decreased abundance of several microbial species or strains known to have potential anti-inflammatory protective effect in cases which they defined as at-risk children who ended up developing celiac disease. So specifically at this conference, we learned of their efforts to investigate a little bit more on those microbial species and to see that they had isolated from children at risk of celiac disease who seemed to potentially protect them from the onset of the disease. Specifically, they identified a unique strain, B. vulgatus, that may exert a beneficial role in protecting the celiac disease epithelium against a gluten-induced break of epithelial tolerance. In other words, in those who had higher levels of this strain, they saw that they were able to decrease the risk of celiac disease. And so this is just kind of speaking to some of the work that CDGEM is looking at going between the genetic predisposition and that you have a family history of celiac disease and trying to understand what's happening in between to get to the celiac disease onset. So they were looking at, that was reviewing intestinal dysbiosis. Another update that they found is they identified a biomarker called zonulin, which seemed to be upregulated or increased preceding the celiac disease diagnosis. I'll have you focus on the middle graph, where the dotted blue lines are the controls, those who do not have a family history of celiac disease, and the red, those who do have celiac disease. And what they saw with the zonulin is that there was a bump around the 18-month mark prior to the onset of the autoimmune process. So it suggests that maybe zonulin may be used as a biomarker for preclinical celiac disease screening in at-risk children. It really just kind of continues the work that CDGEM has been doing in identifying what are potential biomarkers that we may see before the onset of celiac disease. I also wanted to highlight briefly some work that's being done by colleagues in the University of Oslo, where they identified a fecal biomarker named neopterin. And so neopterin is usually found following the activation of T cells, and it usually represents some activation of cellular immunity. It's been used in the studies of inflammatory bowel disease, but the team in Oslo noticed that they also found high levels of fecal neopterin in those with potential celiac disease, which they kind of showed on these two figures here. And so it really just says there might be some other biomarkers coming down the line that may hint at, may be able to help us predict whether they will develop celiac disease. Transitioning a little bit, but still on the topic of epidemiology, we had an interesting talk by Dr. Laura Kievler from Oslo, who showed that there was an increased risk of celiac disease with parents who had higher education, more visits to healthcare, and as well as no financial challenges in the family. And this was not explained by any early childhood infections, dietary factors, family history, or other common health conditions. I think what this really says is that to diagnose and to actually even be able to suspect or evaluate for celiac disease, you need to have regular healthcare contact and also some healthcare literacy in the family. Finally, I wanted to highlight two posters that examined early diet exposures and the association of celiac disease. One was conducted with the Norwegian mother, father, and child cohort study, a unique cohort of over 90,000 pregnant women who were recruited from 1998 to 2008. They used the Diet Diversity Score and Healthy Eating Index, basically two methods of trying to analyze the diversity of their diet, and they found that a more diverse diet in early life was associated with a lower risk of celiac disease, independent of the gluten intake. The second poster on the right is from the TEDdy cohort, which Dr. Liu will probably talk a little bit more about, but it's a prospective cohort of children with and without family history of type 1 diabetes, and looking at environmental factors that can contribute to the disease, and they also look at celiac disease. Specifically, what they found was that higher amounts of dietary fiber in the first 2 years of life were inversely associated with celiac disease, so i.e. it may decrease the risk of celiac disease. We're next going to move to screening. this was an interesting topic and it actually took up a big section of the clinical forum, and it was the question of who to screen and when. Specifically, they first started with Dr. Castillo, who argued in his 2023 paper that we should not be looking at just patients who are at risk, or this case control study, which is basically those with first-degree relatives with celiac disease or just those with symptoms. He argues that asymptomatic patients share the similar characteristics to symptomatic patients, and many are not in the high-risk group. And if you look on the left in his paper, he was showing that in these asymptomatic patients with celiac disease, up to 12% really had no symptoms at all. And so he actually argues that for testing all children who are undergoing blood tests, and he says because usually children don't have blood tests without a reason, whether it's usually because of a health reason, this might be a good way to help close the diagnostic gap. The one issue with this, and it kind of will continue as we talk a little bit more on screening, is that we don't really have a lot of data on cost effectiveness of this, as well as research in the long-reaching consequences of misdiagnosis and anxiety that may come with that additional testing. But this transitions well to our next speaker, who advocated actually not just in testing celiac disease in those who are having blood work, but actually more for mass screening. This is presented by Dr. Castassi, who he actually presented some data that they had done some mass screening initially in some Italian schools, and they screened them looking at their HLA, DQ2 and DQ8. And what they found, after they screened them, if they were positive, they looked further on TTG IgA for diagnosis of celiac disease. And what they found is that 60% of affected subjects were undiagnosed. And perhaps most striking was that 27% of the participants with a diagnosis of celiac disease had no indication for testing for celiac disease by the current active case finding strategy, which I had mentioned before on the prior slide. We went reverse, I apologize. So I think basically it asked the question, it's still the bigger question of how can we screen for celiac disease? And I think what would be very interesting to hear in the coming years is that Italy has actually just started nationwide screening for type 1 diabetes and celiac disease for 1 to 17 years old. It started in September 2023, and they've just completed 1 year of the screening. They're screening children at 2, 6, and 10 years of age, and it utilizes a nationwide network of family pediatricians. It was very interesting to hear them to talk about the infrastructure build that's required to get all individuals screened. And there's also still questions on kind of how to take care of those who are screened but don't end up following up. And so I think this will be an interesting case for us to watch and to see if this is what we need to be following later on. I next want to move towards biopsy, whether versus serological in terms of the diagnosis of celiac disease. I really wanted to highlight the amazing work done by the Celiac Kids group to assess the serological criteria of celiac disease in a large cohort of North American children. As many of you know, our European colleagues have transitioned over to the serological diagnosis of celiac disease, which is defined as requiring a TTG IgA greater than 10 times the upper limit of normal, and on a separate measurement, a positive endomysial IgA antibody. The question our team tried to answer is, can we do the same with serologies drawn in the United States? This is a bit of a busy slide, but I think the main things that I really wanted us to focus on is that, one, there's many different types of assays that are used in the United States. The distribution of it in our cohort is listed on the left on the first column. And then the second thing is that there is a bit of variation in their positive predictive value. I'm going to give you a quick stats review. Positive predictive value is the probability that a patient with a positive or abnormal test result actually has the disease. And so ideally, you want to try and get as close to 100% as possible. And what you can see is that not a single one of these provided 100% positive predictive value. And even when you change the threshold, not just a positive TTG, but a greater than the 10 times upper limit of normal, that's still, we did not find a test that had a positive predictive value of 100% for celiac disease. So I think it's important for us to keep in mind these points when assessing whether we can do the serological diagnosis in the United States. I'm now transitioning a little bit on the social and psychological impact of celiac disease in the gluten-free diet. I thought this image from Dr. Satherley's talk really illustrates the anxiety and the stress around the gluten-free diet that can be there at times. And we know that celiac disease is associated with an increased risk of depression, anxiety, eating disorders, and even ADHD. Specific in the talk, what I wanted to highlight is that they have developed this new food attitudes and behavior assessment called the Celiac Disease Food Attitudes and Behaviors. It's a 11-item validated tool that queries eating attitudes and behaviors resulting from beliefs around cross-contact and food safety. I think now that we have an understanding that there's this risk of eating disorders, it's really important that we know how to assess and be able to monitor for this. So I thought that was a really interesting takeaway from her talk. It's been first validated in adults and now in pediatrics. Now I'm just going to talk about one quick study that was done and highlighted in one of the clinical forums about understanding celiac disease and pneumococcal infection risk in children. This group looked at an administrative database, i.e. billing codes of children who were admitted to the hospital, and they found that there was higher risk of infections by pneumococcus infections, and that also caused longer hospital stays and higher costs, though it had no increased risk of like mortality or death. And I think the important thing of this study is that even though we are not general pediatricians, we are still pediatricians, and that there is importance in monitoring when your patients come to you and about asking their vaccine history and making sure that they're up to date, because there is slight risk of pneumococcal infections for children. I will say the data set does need to be taken with a grain of salt because this is all admissions, and I think most of the treatments for pneumococcal infections are actually done outpatient. And now I'm going to run through a quick highlight of some of the posters. The first, I wanted to highlight this work from our UCSF colleagues who looked at social adversities, that association, and its impact on patient outcomes in pediatric celiac disease. They define social adversity as kind of consisting of whether there be financial strain of affording the costly gluten-free diet, social isolation from dietary restrictions, or a decreased health literacy. And they found that social stigmatization, decreased health knowledge, and mental health comorbidity were all associated with the 2 to 5-fold increased odds of worse patient-reported outcomes in pediatric celiac disease. And I think it really highlights the importance of assessing for these and acknowledging that they do play a role in adherence and outcomes. This was a pretty fascinating study by Children's National looking at the feasibility of at-home GIP testing. Dr. Silvester mentioned what GIPs were earlier, but just a reminder, they're gluten aminogenic peptides, and they're smaller versions of proteins that are resistant to digestion, and they're excreted through stool and urine. And so ideally, it could be used as a screening method to assess gluten exposure in patients with celiac disease on a gluten-free diet. This group specifically applied it in an adolescent group who's not always known to have the best adherence to the gluten-free diet. And I think they really showed that it is feasible for adolescents to use it and could be applied in the short term as a feedback mechanism to guide individuals in the transition of the gluten-free diet. We also had some excellent work from our colleagues at Columbia, where they looked at the perceptions and opinions of pediatric GI providers on non-dietary therapy. And as we know that some of that is potentially coming down the line in the next few years, most medical providers felt that non-dietary therapy in celiac disease was needed as an adjunct to the gluten-free diet rather than a replacement for it. And they really emphasized wanting to be able to understand the safety profile and how it improves the quality of life of the patients before they would consider prescribing it. So I think this is important things to consider as these therapies roll out in the clinical setting. And what are things that our providers on the ground would want to know before they start prescribing these medications? And the next two posters really highlight the practical patient-focused research that was also presented at the symposium. And the first was that washing mitigates risk of gluten cross-contamination. And the second was a review of the impact of a pilot culinary medicine program that has been started by the Celiac Disease Foundation. And it kind of just represents things that are helpful in the day-to-day for our pediatric patients in terms of education and living with the gluten-free diet. They found that there was high level of participation and positive feedback and showed that this might be a good way to be able to talk more about the gluten-free diet on an online setting. So just to conclude, there's different biomarkers besides TTG, IgA, and predicting onset of celiac disease. Clinically, they're not yet available, but there's a lot of things that we're trying to understand to take it from genetic susceptibility to actual development of celiac disease. Mass screening for celiac disease and type 1 diabetes has started in Italy, and we're looking forward to seeing kind of the lessons that we learn and the mechanics and effects of mass screening. There's many large birth cohorts that are identifying dietary and social economic associations. And I think it's actually showing that because celiac disease is so prevalent, we can begin to study this disease in bigger cohorts. And so we should encourage all patients, if possible, to join them because we might be able to identify more associations. And then finally, in the question of biopsy versus serological diagnosis, we probably still need a little bit more data, but I think our understanding that there's some variation around the serological test does allow us to kind of, it's a first step in kind of making that decision. And so thank you.
Great. Thank you very much, Dr. Liu. Wonderful presentation and a lot to think about. And so for my the final presentation of this session, I'm pleased to introduce Dr. Edwin Liu. He's a professor of pediatrics at Children's Hospital Colorado, University of Colorado School of Medicine, and director of the very well-known Colorado Center for Celiac Disease. He has a particular interest in mass screening for celiac disease and prospective cohorts to understand the natural history of disease and in future efforts to predict and even hopefully one day prevent celiac disease. So welcome, Ed. Thanks so much for being with us.
Okay, great. Hopefully you can see these slides here.
Yep, looks good.
Okay, great. Thank you. So, yep, we're going to talk about disease prediction, and hopefully I can give you some crumbs of insight on this. There's my disclosures. And so maybe the first thing I want to show you is just that when we follow kids born in Colorado, basically from the general population, we can find that there's really a rapid onset of celiac disease within that first 10 years of life. So you see that these are kids born from like 1993 to like 2004, 2003, and then another cohort born from 2004 to 2010. They develop celiac disease very quickly within the first 10 years, and after that, it starts to slow down. With their earlier cohort from 93 to 2003, by 10 years, we found that about 2.8% of kids would develop celiac disease. And the newer cohort from 2004 to 2010, it's about 2.4% by 10 years. So it really hasn't changed, and it's still very high in Colorado. So the question is, if we know that these kids are going to be developing disease, how are we able to predict who will and who will not get it, right? I think that's the key question. I will talk briefly about the TEDdy study. TEDdy stands for the Environmental Determinants of Diabetes in the Young. And this is a big study that started in 2004, and it involves 6 clinical centers, a site in Colorado, Washington State, Georgia, and then sites in Germany, Finland, and Sweden. And the goal of TEDdy has been to identify like the factors that trigger type 1 diabetes and celiac disease. And so it's been an observational multi-center study that follows kids up to 15 years of age. So we're really at the last year of TEDdy now. Like nearly all the kids have reached that 15-year time point. And, these are kids who have the high risk HLA genotype. So they're at risk for celiac disease because there's no point in following kids who don't have a risk because they're just pretty much not going to get it. The TEDdy protocol for these kids that are enrolled, and there were like about 8,000 kids that have been followed through these 6 centers, are that from birth, they get blood drawn every 3 months for the first 4 years of life. And then after age 4, they get blood drawn every 6 months. And, they get frequent clinic visits, they get tested frequently for development of islet antibodies for diabetes and also the celiac disease antibodies. Stools collected very, very frequently. We get like toenail clippings, we get their water samples, we check their saliva, we do nasal swabs, we do a lot of things, including urine, check their DNA, get their blood. And there's also a lot of questionnaires, right? In terms of like, what foods are you eating? When did you get fevers, your antibiotics? Are you taking probiotics? What are your vaccinations? Those kinds of things. And so these kids are essentially put under a microscope to try to identify what factors may be leading up to development of celiac disease or diabetes. So in other words, when they actually do develop antibodies for one of the two diseases, you can go back and look at everything in the past. So one of the first things I will show you here is that autoimmunity does begin very early, sort of like that graph that we looked at in Colorado. So, the peak onset of celiac disease antibodies and also celiac disease diagnosis is 2 to 3 years of age in these kids in TEDdy. So it happens very early. And then, the rate of new cases decreases as you get older, but it certainly still happens. And then on the right side for diabetes, you're looking at the incidence of diabetes or islet autoantibodies, and that seroconversion happens very early as well, even earlier than celiac disease. By 9 months of age, you're already starting to see a spike in kids who develop those antibodies, and then the rate of new cases starts to slow down. So you start to think about disease prediction and what's the utility? Why would we want to do it? And there's a lot of reasons for doing this. For personalized medicine, for example, this can aid us in the diagnosis of uncertain cases, if you know that someone's at very, very high risk, or you can select individuals who might be eligible for specific future therapies, or you could identify high-risk kids that might need more closer monitoring. And then from the population-based practice, this could facilitate the surveillance of high-risk individuals, or it could even facilitate recruitment of high-risk individuals into clinical trials. So when we talk about disease prediction, probably the first thing we always talk about is HLA, right? They're main genes, DQ2 and DQ8. Those are the two big genes. And, we find that DQ2 being the highest risk gene, when you have two copies of DQ2, your risk of developing antibodies over time is very high compared to having only one copy of DQ2, which is in the orange, compared to having DQ8. So, we can see that you can start to stratify risk of celiac disease just by looking at their HLA genotypes, but that in itself really isn't sufficient. Certainly, we know that HLA genotype is the single most important risk factor for celiac disease, and it can identify 30 to 40% of the population who has a risk of actually getting celiac disease. Remember, not everyone with the genes will develop disease. But the risk of disease by each of these individual HLA genotypes really varies greatly depending on what population you're looking at. So you look at this table here, looking at the range of cumulative risk of celiac disease by age 10 for these different TEDdy sites. Look at the very bottom one where it's DQ2, DQ2. So again, that's the highest risk genotype for developing disease, but the range goes from 9% to as high as 28% by age 10. And if you happen to be born in Washington State, then your risk of developing celiac disease by age 10 with DQ2, DQ2 is only 9%, which is still very high, but not as high as that 28% that we're seeing in those who are born in Sweden. And so because that tells you that the genes for HLA just aren't enough to predict, right? There's a lot of other things that play a role, including other genes and also a ton in terms of the environmental influence. So, looking past just HLA, you start adding other genes like non-HLA genes, and then you start looking at what we call a polygenic risk score. And so adding HLA plus non-HLA genes can improve prediction. And this was shown by this group, Seth Sharp, back in 2020, where they developed this polygenic risk score. And bottom line is there's many other celiac disease related genes, right? HLA is the big one, DQ2 and DQ8. And there's what we call an odds ratio of about 6, which is very, very high, compared to all the other genes, which is over 40 additional celiac disease related genes where they have an odds ratio of only about 1.2 to 1.36. So all these other genes contribute much less. But when you add them up together in terms of developing some sort of risk score, and you measure them by looking at SNPs, like this 42 SNP polygenic risk score can provide you with this sort of continuous risk score that's present at birth, and it's constant over a lifetime because these are just genes. And so you already know what the genes are at birth. And this kind of polygenic risk score certainly might be more cost efficient than clinical HLA typing, as long as 100% accuracy in typing isn't required. But there's certainly a potential for clinical translation for this. The thing is, it hasn't really taken off, right? I mean, we aren't using this clinically for disease prediction, and certainly there's a lot of reasons for this. There's limitations in these kinds of polygenic risk scores. For one thing, these polygenic risk scores have been developed from a population of European ancestry. right? And so it hasn't really been tested out in other cohorts of different ancestries. And then there also might be rare genetic variants and also like gene-to-gene interactions that could be contributing to disease risk that these kinds of polygenic risk scores aren't really representing. And you have to remember that these kinds of polygenic risk scores only account for the heritable component of a disease and completely ignores like the environmental factors and lifestyle factors. And these are the kind of things that we call like the exposome, right? And then finally, like there's limited guidelines for like assessing clinical readiness of a polygenic risk score, meaning as a clinician, well, how do you actually communicate this kind of risk to an individual and how should it actually inform our clinical judgment? So we don't know how to use these things yet. Now, the next thing would be what we call a combined risk score. And this is combining multiple risk factors into a single score. For example, combining your genes with other kind of factors. And there's an initial attempt at a combined risk score through the Prevent CD group, where they could give you a personalized risk score and screening advice for an individual with a family history of celiac disease based on age, sex, and HLA-DQ. And so on that bottom left corner is like, the website for this if you wanted to play around with it. But again, this isn't something that we're using clinically. But you go to the website, you input your characteristics, and like, as an example, in a prediction model, let's say you've got a 3-year-old with a family history of celiac disease. You're female, you're DQ2 homozygous, meaning you've got 2 copies of DQ2, and you have 2 or more family members with celiac disease. The prediction would be that you've got a 31% risk of celiac disease by age 10. Okay, so with this combined risk score, this study actually looked at a lot of other factors to try to make this a lot more elaborate, but none of those other factors really moved the needle. So they were stuck with just family history, age, sex, and HLA. But it's a good start. But of course, there's many, many other factors that contribute, that lead to the development of celiac disease in childhood. And it's very complicated. I mean, there's a lot of interactions with these factors. Not all these factors have equal weight in terms of leading to disease. And when we look at all the pediatric perspective cohorts that Dr. Du had mentioned before, we find that, like, in general, things that increase risk are going to be certain genetic factors, right? There's a role of infections, there's a role of gluten intake in early childhood. There's a role of vitamin D, and also where you live. But things that can decrease your risk would be, to some degree, like having a rotavirus vaccine. There's also certain protective genes, like a Mediterranean diet can be protective in some ways. And then, the measurable biologic data, though, for all these studies is really lacking, meaning measuring omics, whether it's like measuring proteomics or viromics or, metabolomics, those kinds of things. Like, so we've got all the blood samples, but we haven't tested them for actual biologic data. And most of the data that's derived from these prospective cohorts so far have been through questionnaires, right? And that makes it a little bit soft. And it also, importantly, like, there's a lot that we know in kids, but not enough is known yet about these kinds of risk factors in adults. So when we think about trying to include all these things, okay, to develop a combined risk score, you've got up top, you've got the genetic factors like HLA or a polygenic risk score. And then you've got other patient factors like country of birth, sex, family history, other maternal factors. And then on the bottom, you have like the environmental factors, right, related to the exposome, like your lifestyle, infections, diet, microbiome, occupational exposures. And then, like, I tend to look at the top ones as fixed characteristics, meaning these things are essentially present at birth, right? Whereas the bottom ones are variable characteristics, and these things occur over a lifetime. Okay, and then you put these together and you could come up with a combined risk score. It'd be extremely complicated, but you can, right? And depending on which factors are the most important. Now, the top ones, the fixed characteristics, are really the irritability part of things, right? And these are useful for like very early disease prediction. So there might be more usefulness in predicting disease in a child compared to an adult, compared to the bottom ones, the variable characteristics, where are more malleable, right? Meaning, like, these things are potentially preventable risk factors. And so there may be more utility in using these in a combined risk score for an adult compared to a child. Now, this is supposed to be a very complicated slide. This includes 503 kids in Teddy who actually developed celiac disease. And like each of these kids is stacked up, up along the y-axis going up, and then going across, you see blue dots, and then you see a red line or a red dot, and then you see the green ones. So each one of these is each of those points is a TTG level, okay, for a child over 50 months, 100 months, 150 months. So basically, the blue dots tell you that that's the first time a child followed through Teddy became TTG antibody positive, okay? And then every other green dot after that meant that they were still TTG antibody positive. The red dot tells you when they actually received the celiac disease diagnosis. So bottom line is, when you look at this in terms of like a cluster analysis, you see that like at the very bottom, the bottom left, you see that the blue dots and the red dots are very close together, meaning these kids developed celiac disease, or they developed antibodies at a very early age, and they got diagnosed very quickly. On the other hand, when you go work your way up the line, you see that there's also kids who get their first TTG antibody positive years later, right? And then they get diagnosed at some point with celiac disease. So what this tells us is that like the factors that may be leading to triggering disease in those kids who develop disease very early may also be different from the factors that lead to disease development in kids later in life, right? And so what should disease prediction actually look like? Well, I do think a combined risk score would be best, but hopefully it's not too complicated. But with all the data there, it's going to be complicated. It should really try to encompass the entire genome and also the exposome. And it's got to account for these, what we call like important principles of exposome research, meaning you got to consider the potential for cumulative exposures, not just one infection, but multiple infections on the risk of disease. Maybe there's critical time windows, especially early on in childhood, that might make kids much more susceptible to developing disease. What about the lag time between an exposure and then eventual disease onset? You got to consider how exposomes could interact with each other, and you got to consider, like, should we be assessing this in a cross-sectional manner or looking at this in a dynamic exposure? So regardless of how a combined risk score is going to look like, it has to be also practical for clinical or research use, and it has to be timely. So these have to be data inputs that are reasonable to obtain clinically, and timely meaning you have to be able to predict it at an early age. You can't wait for a lifetime accumulation of infections before you decide that someone's at risk, for example. So, it looks really complicated, but the important thing is we can use artificial intelligence, right? And I'm not an expert in AI. When we gave this talk at the meeting, we actually had a bioinformatics person do this, but I'll just summarize some things with you about AI, that it's a broad field that encompasses many different disciplines. It has to be multidisciplinary, right? And it's an umbrella term referring to a range of, computational methods, including something called regression, clustering, sort of like that graph, that really complicated looking figure I showed you, machine learning, and deep learning. And using artificial intelligence, it can be used to develop prediction models, and you'd have to identify combinations that are needed for a combined risk score with deep learning. And so, yes, you can actually combine all of these data layers together, and it gives you the potential for more accurately classifying patients, and then you can identify a combination of factors that can lead to disease. But the important thing is you still need quality data, right? So bottom line is garbage in, garbage out. So, this is sort of where the future is going to be in terms of trying to develop disease prediction, but it's always a reminder that it can't be too complicated. It has to be very accessible to clinicians. And my last slide here is just in terms of the future of disease prediction as a summary is, I think it's a combined risk score, and it should be designed for its intended use, whether it's academic to really try to learn about different kinds of triggers, or for practical or clinical application. I think that we still need better biologic markers or inputs for disease prediction. And then there's also little known about the risk factors of celiac disease in adults. And so that means that we need these kinds of prospective cohorts in adults somehow. And there's also many factors that contribute to disease risk, but the fact is not all of them are going to be that important, right? There's a lot of things that are identified that contribute probably very, very little bit, but it's still reported as increasing risk. And you need to be able to put that in perspective, right? AI can certainly help model these complex, multifactorial interactive natures of the genome and the exposomes. And then, developing this kind of combined risk score is going to require collaboration, right, between clinicians, basic scientists, and bioinformatics. So that's all I have, and I hope this was helpful for you guys. Thank you for your attention.
Thank you so much, Dr. Liu. Really insightful and such an important source of data, the whole TEDdy study. So appreciate all the hard work. And so we are actually a few minutes ahead of time. Thank you, speakers, both for the great presentations, but for keeping us on time. This is great because we have such a broad and thoughtful range of questions to get to. Again, we will not get to all of them, but we will do our best. So I believe you are all online. Excellent. So why don't we start with one, and maybe we'll do like a quick round robin to warm up with this about how we think about the risks of small occasional gluten exposures. Do we worry about long-term complications or problems related to this? Is it just part of life? What do you talk about in your clinic? And I guess I'll just go in order, maybe Ed, then Nan, then Jocelyn.
Sure, I'd be happy to give you my opinion on it. And I think at some point, there's a point where we run out of data to support what we say, and it becomes more philosophy. But my philosophy, if you're worried about small, occasional, like rare exposures, it's not harmful. I'm not worried about that, and I always tell my patients, because I worry about the concept of hypervigilance versus being safe, that in general, tell me what you guys think, but I tell them that if you know how to be gluten-free and you've got the right intention, gluten is only harmful when you do it on purpose. So just don't do it on purpose, but I'm certainly not worried about those accidental exposures.
Great.
I would actually say very similar to Ed. I kind of talk about how the world right now is not very friendly to gluten-free. And so also trying to balance that hypervigilance, as well as we know the risk of eating disorders in our kids. And so I often say, as again, not doing it intentionally, that there's some mistakes that we made, but it's actually a really good learning for us to know where we could potentially get tripped up by the world. And that in the long run, if it's, as you say, spaced out and not frequent, I don't really have the data to say of the necessarily long-term effects. And so similar to Ed, I kind of say philosophically, just for you to live in this world that's not friendly to gluten-free, I think this is the best philosophy that we can follow.
Thank you.
I don't know. I think it's hard as a pediatric gastroenterologist because I, by definition, don't see long-term outcomes. But I do see that there's lots of harm that comes, as Drs. Liu and Du have already said, about being fearful of gluten. And I do feel it's somewhat inevitable. And we do have data that people get exposed to gluten. And so I think, again, awareness is really important. And to be totally honest, I vacillate on how I feel about this. And I don't have an established position because, as Ed said, I don't think we have the data to have a position.
Thank you. No, always a good question, and something that's on every, I feel like we talk about in every clinic. Excellent. So a next question about testing, and the point that a lot of what we know about celiac testing, especially TTG accuracy, comes from European populations and maybe less accurate, especially there's some data from Amanda Cartier's work showing it might be less accurate in Black patients. How do we think about this? Is this a big concern? Could we be using the screening test we typically do? Could we be biasing to certain populations over others? And I'm not sure who wants to jump in on that. Can call on you, Ed.
So, if the question is like, how well does the TTG rules, right, apply, and like how reliable are they in other populations? It's a great question. The ESPIG and the European guidelines for diagnosing celiac disease by blood testing, it's been well vetted in Europe, but it hasn't been very well vetted in the US. Practically speaking, we will use it when we've got other, when our options are limited and when it serves our purposes. But, in general, we're still relying on biopsies. It needs to be tested out because also, as Dr. Du pointed out, like assays are very different. And so you need to understand your assay to be able to know how reliable it is. But that's an area of research that needs to be done for us, is to try to identify whether or not we can find the right combinations and the right levels of the blood test and which blood test to really try to identify celiac disease in different populations are very, very important. We can't just look at one population and apply this to the whole U.S. We're a very, very heterogeneous population.
Yeah, thank you. It's definitely an area that needs more work. I agree. And I think we will, ideally in some point we will have maybe, ethnicity, population specific cutoff levels. So to help us guide. But I do think this is one reason why we can't give up the biopsy totally yet, because it is, it does show the disease. So excellent. Thank you. Great question here that I think I'll give to Jocelyn. You've done a lot of this work in this area, asking about GIP testing, gluten immunogenic peptide testing in your underestimate home GIP testing. Is it better than measuring TTG antibodies for understanding gluten exposure? How should we think about that? Which one is a good indicator of intestinal damage?
Good question. I actually gave a talk about this at the meeting because I think we often think about GIPs and celiac antibodies, TTG or deamidoglidine peptide, DGP, as the tools we have to look at celiac disease, but they actually are functionally doing very different things, because we know that not everybody makes TTG, but in people with celiac disease who do make TTG, that's driven by gluten. And there is a nice, very technical abstract showing that it is definitely, that is what is happening in terms of how the cells are presenting it. And so the antibodies are driven by gluten, but again, it's a threshold thing. How much gluten do you have to have enough antibody that it's going to go from your intestine into your blood and you're going to be able to pick it up? And what's the time course of that? Whereas if we're looking at GIPs, we're looking at, okay, did you actually get gluten? And I think we have to remember there's a disconnect between the disease and the treatment. And so are we actually looking to see if somebody's on the treatment, or are we looking to see that their intestine or their disease is healthy? And those are different questions. And I think we have to be more sophisticated and think of them separately. And they have different purposes. In terms of GIP testing, I think from what we know, stool is probably better than urine, even though nobody ever wants to do stool, just because you have a better chance of catching it. And how long it takes for things to work through varies between people. So you could miss it. So if you're worried about ongoing gluten exposure, more tests are better than less.
Great. Thank you. And so let's go to Dr. Du for this one. This one was partially answered in the chat, but I want to hit it again anyway. So I think we have greater awareness that celiac disease can present with mood disorders and attention disorders and these type of issues, neurological, psychological disorders than we used to. But to my knowledge, we haven't really been looking at screening in that population. And this question is really about, should populations that are at specifically high risk of these type of psychological disorders, mood disorders, such as, kids maybe who have been in trouble with juvenile detention centers, incarceration, would this be a potentially interesting place to look for higher rates of celiac disease? Or is there anything, or when you see even children with ADHD in your practice, do you think pediatric gastroenterologists or pediatricians in general are thinking about celiac disease, and should they?
I think that's a really good question. And I kind of want to divide it in from like a practical standpoint and then from a research standpoint, because I think Dr. Silvester began to answer that a little bit in the chat, in that populations that are incarcerated or potentially in the juvenile system, those are much harder to study because there's this question of ethics and consent and whether they'd be able to freely give their consent. So it's a harder population to study. But I think in terms of the question, in terms of those with like ADHD diagnoses or behavioral concerns or issues, I think actually it's a really good point. And I don't know if we've done as much education about that to the general pediatricians, which I think would probably be the first step. I will say that oftentimes after many of the children get diagnosed with celiac disease in my clinic, I oftentimes will do a pretty large review of systems and asking, hey, have you noticed behaviors have changed? Have anything else been different? Because sometimes even being on the gluten-free diet, they will notice some changes there. But I do agree we might need to be doing a better job of having that as something on pediatricians' radars to potentially screen. But I think I also don't have all the information in terms of the risk associated with that. So that's how I would answer that, if that's okay.
Yeah, no, thank you. It's not, I mean, these questions are really good. They're not easy. So I think that's great. And as always, I'm calling on people, but if anyone else, Ed or Jocelyn, have other things to add to any of these questions, please feel free to jump in. Don't wait for me. But I'm not moving on to the next one, and maybe just keeping going the cycle. I'll give this one to you, Ed. So there was an idea of, if we're unsure of what to do with screening, maybe we should look specifically at a few special risk populations. And one that was suggested was the Down syndrome population, or trisomy 21, which we know has a higher risk of celiac disease. Would this be potentially a good area to do a screening study and really understand the benefits and costs?
I think it's already a population that's at higher risk compared to, for example, if you think about like just general population screening, which is just a lower risk. But certainly kids with trisomy 21 Down syndrome, they're at higher risk, and it's a really important group to be screening. And the pediatric GI guidelines do say that we should be screening for celiac disease in kids with Down syndrome. Of course, I think like the American Academy of Pediatrics doesn't specifically recommend that though. So there's a bit of a difference. But yes, I mean, I think there's already a lot of experience in terms of screening these individuals who are at high risk. And so we have a lot of that. I think the area right now, though, is going to be like, what's it look like when we screen everybody? I personally feel like we should be screening everybody. Certainly voluntarily, but that way you don't have to worry. I think someone mentioned that in the comments. You don't need to worry about like kind of people falling through the gaps and all those things like that. And so that's one of the pushes we're making is actually mass screening and looking at like the cost, and importantly also looking at how we manage a screening positive person in a responsible way.
Okay. On to Jocelyn. Why don't we do one? We've had a couple questions for families at high risk. Say they already have a kid or a parent with celiac disease and they have another one. Are there thoughts about infant feeding practices that really affect the risk, yes or no? And if so, what are they? Or is there any thought that maybe keeping kids away from gluten while they were young, or anything the mother should be eating? Is there just anything we know about that is clearer than it was in the past?
I don't know. I think there's lots of things we think, but I don't know how much we know. I think one of the things that's complicated is that it might be that it depends who you're looking at, and people who have a family history of celiac disease and who may have the genes are, of course, a very high risk population. And so that might be different than if you look at the average population where most of them don't have celiac disease anyway. What I counsel my patients in clinic based on minimal evidence is that it's important to be exposed to gluten, because we know from other studies that if you don't get exposed to an allergen, then you're more likely to develop anaphylaxis. And anaphylaxis to wheat is a huge problem if you get it. And so exposure to gluten would theoretically reduce your risk of that dramatically. And then because there's a risk, you can screen. And this is maybe one area where genetic testing is helpful, because then, as Dr. Liu showed, you can risk stratify and have an idea of just how high the risk might be.
I'd be happy to add something to that too, because I agree with Dr. Silvester. A lot of research in terms of like infant feeding practices and the risk of disease, but we have to interpret these things very carefully, because none of this is able to be translated directly into recommendations, right? But in general, I mean, we've looked at like feeding gluten too early, and that was initially thought to be a risk, but in fact, it's just not. I mean, I agree with Dr. Silvester. I mean, it doesn't help, I don't think. We don't have evidence of it, of actually like delaying gluten, and skipping it. Right now the recommendations are feed your kid according to the AAP guidelines, and the one data that suggests the role of gluten is in general, like the more gluten you eat early on in childhood, the more it raises your risk a little bit. But we really can't translate that into like how much gluten, right? We don't know, like there is no number for this. And so at this point, if we knew what the factors were that could prevent disease, we would be getting out there right away, but we just don't know enough about this yet.
Great. Thank you. No, it really is. I mean, I thought we'd be much further along in answering that question than we are today. And I feel like all the data just makes this issue more and more, less and less sure about what to do. Maybe we got time for a couple more. Nan, there was a couple questions. You answered one, thank you, already in the chat about pneumococcal vaccination. But there was also a question from earlier about, kids who have ongoing respiratory infections or seem like they're more frequent or more severe in children with celiac disease than not, at least anecdotally in some families. Do we know anything about this? Is this driving some of the vaccination recommendations? What do you tell your patients or their families if they have concerns that they're getting sick a little bit more frequently or more severe than their siblings or peers without celiac disease seem to?
Yeah, and just to directly answer the question that had been put in the chat, I'm not quite sure exactly what they do in the UK about vaccinations with pneumovax, but usually in the United States, we get 4 doses of that vaccine when they're quite little before age 2. There's usually 4 doses, and then that's not repeated until after age 65. And so the study that I presented, I do want to stress, was based off of hospitalizations of pediatric patients in the United States, and they actually didn't have their vaccine status or data there. The key point of that is that they were saying that celiac patients, when they were hospitalized, there was just a higher number of celiac patients compared to when you compared it to those without celiac disease. And so I take it with a grain of salt because oftentimes in pediatrics, we're very lucky in that our kids often don't need to be admitted to the hospital to be treating these infections caused by that bacteria because it usually can be managed outpatient. So I think I like to say the denominator or the actual number is a little distorted, but it's kind of what you get with the database, and it's it's one way to look at it to at least get a hint of maybe what's going on. And so I take that study with a little bit of a grain of salt, and that's why I think the authors of that study did not say that there needs to be additional pneumococcal vaccines added to the vaccine regimen, which is sometimes recommended for those who, do not have a spleen or those in our hematology oncology patients. So they did not advocate for that in that paper directly, because I think that data is not directly there. I think in terms of the question of whether there's increased viral infections compared to their peers, I might actually draw upon my Dr. Silvester and Dr. Liu in terms of the exact answer to that, because I think sometimes it is hard to be able to answer that too eloquently, because I do think probably it's good to make sure that they're adhering to the gluten-free diet. So I think if they're in the early stages, I want to make sure that they're adhering to the gluten-free diet, and from an immune tolerance standpoint, we're doing our best there. But and then sometimes I say, well, a child with celiac disease is still a child, and that if they're truly having more viral infections, do I need to think more broadly of an additional workup for them? But I'll also let Dr. Silvester and Dr. Liu weigh in just to make sure I'm not missing anything there with that question too.
No, I agree.
Looks like you got it. All right. And with that, I think we are out of time for questions. Thank you so much, Dr. Liu, Dr. Nan, and Dr. Silvester, for joining us, for spending this time and really providing so much practical information. And with that, again, this will be online. If you missed anything, you want to go back or share it with friends, feel free. With that, I will pass it over to Chris to close us off. Thank you again, everyone, for the great questions, and to our panelists.
Sounds good. And thank you, Dr. Leffler, and thank you again to all of our presenters and attendees for your participation. We hope that everyone in attendance found this webinar to be educational and helpful. Please watch for announcement of topics for our November 2024 Harvard Medical School National Celiac Association webinar series by visiting our websites, keeping an eye on our social media accounts for updates. That announcement will be made very soon. And so from all of us here, we look forward to seeing you next time, and we thank you for your continued support. Have a great rest of your day.